And today we will be focusing on outpatient department, and clearly it's not mentioned in children, but with my degree that I am a pediatrician, and so I'll be restricting my talk and discussions to children. Leptospirosis, not very common, but still we need to keep a watch in monsoon. So how do we go about it? Let us first do some self-assessment. Then I will be going through cases and we'll discuss some salient features of dengue, malaria, leptospirosis, how to use the laboratory and clinical parameters to make a reasonable, rational choice and avoid unnecessary investigations. But also, more importantly, you will diagnose and prevent complications to the patient and also to yourself.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So by the time we start, we are already in monsoon, and in a way, we worry about monsoon. We also look forward to monsoon for various reasons. And today we will be focusing on outpatient department, and clearly it's not mentioned in children, but with my degree that I am a pediatrician, and so I'll be restricting my talk and discussions to children. Now, as we know, we have many fevers which are special to monsoon or more commonly occurring in monsoon. Now, children don't come with these label of dengue, malaria, chikungunya. So commonly they come with either fever, cough, cold, they come with fever, cough, cold, rash, or they come with loose motions, or sometimes they come with peculiar features which will help us make a diagnosis. So we will today try and focus on the worrisome monsoon fever, and that is the dengue fever. We are also seeing, at least in Mumbai, in the last couple of years, the resurgence of malaria and arrival of chikungunya, which we were fortunately able to control the malaria part for last few years. But in the last couple of years, we are back with the nuisance of malaria. Leptospirosis, not very common, but still we need to keep a watch in monsoon. Then there are cough, cold fevers, the viral fevers that increase, and the flu is now complicated with the COVID-19 symptoms. Then we have gastroenteritis and GI symptoms, which can start with loose motions, vomiting, and fever. And you could be dealing more commonly with viral gastroenteritis, but also sometimes with bacillary or amoebic dysenteries, and occasionally with enteric infections, namely typhoid or Shigella. And as the monsoon peaks, and you will slowly start getting toddlers with this relatively new infection, that is the hand, foot, mouth. So, how do we go about it? Let us first do some self assessment. Then I will be going through cases and we'll discuss some salient features of dengue, malaria, leptospirosis, how to use the laboratory and clinical parameters to make a reasonable, rational choice on your diagnosis so that you can start treatment early, you can avoid unnecessary treatment and avoid unnecessary investigations. But also, more importantly, you will diagnose and prevent complications to the patient and also to yourself. So let's jump into this. The next few slides, there are images, and I would like you to write in the comment box the diagnosis that you think are more likely. So it could be from either a flu or a viral URTI. It could be an image of a child with dengue, malaria, leptospirosis, or none of the above. And if you feel it doesn't fit into any one of them, feel free to write your own diagnosis. So many of these images are courtesy of my dear friend Dr. Hiren Doshi, who is a director of PICU and ICU at our hospital, at Nanavati Max Hospital, and so the due acknowledgement for the same. Sorry. So image 1. Can you tell us what this is in your comment box? Are you dealing with viral, bacterial infection? Are you dealing? Is this an image? Okay. I'm not able to see. Yeah, follicular tonsillitis, Dr. Bagadi has written. That is very correct. Next, let's look at another image. Here also, child has come with fever, cough, and throat pain. Okay, so let me know your thoughts. This looks like viral. This looks like bacterial. This looks like pharyngitis, tonsillitis. Okay, so I will not wait for your answers, but I will show these slides again in the next discussion. So this I would think more in terms of viral, because if you see carefully, the posterior pharyngeal wall, I'm not sure whether you can see the air. Dr. Sanika, is my arrow seen on the image?
No, sir.
Is it possible for me to create a marker?
Yes, sir. I'll just check and I'll be back.
It's okay, don't worry.
No.
So you can see the posterior pharyngeal wall here, and that is where you can see the hyperemia, and you can see the granularity, which is the classical feature of granular pharyngitis, and that would mean a viral pharyngitis, which could be many different viruses. Could be flu virus, could be COVID-19, could be adenovirus, could be rhinovirus, could be many of those. Here, if you see classically, we are trying to show you the capillary refill time. And in small babies, in infants and newborns, we like to see it on the sole rather than seeing in the nail bed. And this is another image, which also is a monsoon fever that I spoke about. Any thoughts on this one? This child had fever with abdominal pain, nausea. On day 4 or 5, fever became little less. Then the eye started becoming this color and the urine was dark yellow. Leptospirosis. Dr. Amit is absolutely on the money. And so important here is to note the type of redness that you see in the eye. This is the conjunctival suffocation. And that means there is no discharge, but there is redness and little bit of edema or swelling of the conjunctiva. This is like a hallmark feature of leptospirosis. And this one here you see is the flushing, which you see in children with dengue fever. Okay, so let's jump on to the cases now. We have a 6-year-old who presented with high fever and 102 for 2 days, cold and cough for 2 days, not irritable, responds to paracetamol. So on examination, when we examined, we felt that child had congested throat, tonsils were not inflamed, and there were no liver and spleen palpable. So what would be your diagnosis? So currently we would be first on day 2 with high fever and upper respiratory symptoms. You would be thinking in terms of upper respiratory infection, which could be a flu, COVID, or it could even be an early dengue fever, because that would also present in the initial phases in the same way. Now, we have seen that every year a COVID different strains present in different forms. So we will see how this time the COVID is different or not different. Whatever we have seen, few patients of swab proven COVID, they are generally mild disease, mild symptomatology for children compared to flu, which comes with very high fever, 102, 103, 104, lasts for 48 hours. We have significant upper respiratory symptoms along with body ache, muscle pain, and headaches. On the other hand, COVID has a relatively milder presentation in children. Anosmia in young children is very difficult to make out, and adolescents have, at least majority of them have not reported that symptoms for the current season of COVID. Sorry. So what are you going to do? Are you going to do any investigations, or are we going to wait and watch? So I would say on day 2 of fever with this symptomatology, and most importantly, no pre-existing medical condition in the child, one would not want to do anything. I would not start oseltamivir, and I would not send any investigations. But if there was any pre-existing condition, or if there is a family member or a contact who has either a kidney transplant, liver transplant, some severe medical condition, high risk patient, recently recovered, etc., then it would be important to make a diagnosis because of various reasons. If you make a diagnosis and if it is influenza, then you could start oseltamivir for this patient, and you can put the contacts on prophylactic oseltamivir. Also, once you have a diagnosis, the isolation automatically becomes more important and more rigorous in the family. So what will you do? Would you send a CBC? In first 48 hours, if you send CBC, it's almost never going to be conclusive for viral against bacterial. If you have sent a simultaneous dengue NS1 or a malarial parasite or a rapid malaria test and that comes positive, that is a different story. So then we are left with swabs, and now we have multiple types of swabs available. So let's spend a few minutes, let's spend a couple of minutes on deciding which swab should be sent and when. Remember, we are talking about outpatient children management currently in this talk. So we have to remember that when you send a single PCR test, it's always going to be most reliable. Multiplex PCR requires higher copies of viruses to get the test positive. So always try to send disease-specific test. So if you are looking for COVID, it's good to send for COVID. If you are looking for influenza, send for influenza. Now, it is a different story that sometimes with the same amount of money, you're going to get more answers, or various other viruses will get covered. I personally prefer to send for influenza panel, and many times it will cover RSV and it will cover COVID. Now, the advantage of doing this is, especially in younger children, when you're doing, if you get RSV positive, you know for sure you are not going to give oseltamivir, and you know that you don't require to give antibiotics, at least in the early phases when you are not looking at any complications. On the other hand, if the child is very sick and you need hospitalization, or if the child is in the ICU and you want a quick answer, then a BioFire nasopharyngeal swab is definitely very useful, because it will not only tell you with certainty, speed, and also more number of organisms will be checked for the same. So in emergency and in critical situations, a BioFire definitely scores over many other conditions. Now, a couple of years back, we had a major epidemic of adenovirus, where children were very sick, high-grade fever, rash, red eyes, some of them coming with simultaneous GI symptoms. And to diagnose them versus many other conditions, we were using PCR multiplex panel, and that was quite good because the cost of that was half of that of BioFire. And though the results were coming after 24 hours instead of 4 to 6 hours, it was okay because we were not in an urgent need to make that diagnosis. So friends, with this we conclude about the swab test, that do the swab only if you are going to treat, or if there is a pre-existing medical condition either with the patient or the family. And in a worst case situation, if you want to start oseltamivir without a flu test, you are completely justified and are allowed to use it. Just make sure that you have adequate indication to do the same. So we showed you these three images. In the first image, if you see, this child would have probably a viral granular pharyngitis. On the second one, if you see the middle one, that is, there are multiple petechiae on the palate. There is edema of the uvula and there is hyperemia of the tonsils. Now, this would be more like a bacterial pharyngitis, and one would think about giving antibiotics here. The third one is clearly a follicular tonsillitis, and one would need to treat accordingly. Now you have another 6-year-old, high grade fever, 102. Now on day 4 comes to you, also complaining there is cough for 3 days. The child is not irritable, responds to paracetamol. Now here you would want to differentiate between a viral fever versus any other condition. Now remember, majority of the viral fever starts subsiding by day 3, not necessarily go away by day 3, but start subsiding by day 3. So day 4, I would put viral fever still highest, but I would start looking for many other conditions. So I would look for rash on the body. Typically, if you see flushing, if you see any petechiae, then you would be concerned. You would ask history of retroorbital pain. You would make sure that the vitals are good, the blood pressure is normal, the gap between the systolic and diastolic has not become narrow, the child is not having any warning or danger signs of dengue, and of course the CRT, the urine output, and the sensorium, including the respiratory rate and heart rate, are within normal limits. If all these are there, I would rather send some investigations and monitor, and not be in a rush to admit the patient. So now the same patient improved after day 4. You have already sent the investigations and you are waiting for the investigations report to come. The parents send the child to school, and next day morning the child has fever. So what are we going to do now? Now, whenever there is a biphasic fever or the fever returns after a gap of 24 to 48 hours, it could still be only a viral fever, and the child should be comfortable, temperature should be around 100, and child should get better next day. So what do we mean by that? If the child had fever and then no fever and then there is only a small hump, then we are not worried about it. Then we are looking more and more in terms of viral fever. But on the other hand, if the child has this kind of scenario where the child is showing signs of flushing, the CRT is delayed, there could be a mild abdominal fullness, chest sounds could be little less on one side, then you would start thinking in terms of third spacing. And this child could be tired. If you see the blood pressure, the systolic 100 for a child may appear, 6-year-old may appear to be okay, but if you see there is a narrow pulse pressure and CRT is already 4 seconds. So all these are danger signs and one would immediately admit this patient. Of course, if the child is looking toxic, has high fever, but has dark urine and liver is palpable, we already discussed, look for the eyes, look for urine, and look for liver palpability. If there is renal involvement with jaundice and fever for some time, think of leptospirosis, start treatment, admit a child. Now you have this patient on day 6, not this patient, but a patient who comes to you on day 6 of fever, and there are no clinically localizing signs. The fever was always there, 100, 101, 102. They have not measured, but they have been giving paracetamol 2 or 3 times a day. Once or twice they have had to do full body sponging for this child. So now though you are on day 6 and you have not been able to localize, there is no neck stiffness, the child sensorium is normal, other parameters are stable. So you are looking at a non-localizing bacterial infection. Now what do you mean by that? The commonest non-localizing and bacterial infection, as we all know, is enteric fever or typhoid fever. But we must not forget that beyond day 5, look for, as the days pass, the longer the duration of fever, lesser are chances of it being infective. The only exception there is tuberculosis and occasionally EB virus. And what would you do here? Before you send fever PCR panels, which are now in vogue, make sure you send a good lab. You find a good lab and send a back-tech blood culture. Because nowadays you will get results within 24 to 48 hours of salmonella positive or paratyphoid positive, and you will be very confident that this child is having only this, and you can start treatment and wait for your treatment to continue. What are the different PCR panels? I don't think we have enough time to discuss all of them, but I would say that reserve PCR panels only when you are after day 4 and 5, you are not sure what you are dealing with, and you don't want to spend too much money on doing different tests, and the fever PCR panel is coming out less expensive. Because remember that dengue NS1 is a far more sensitive test than dengue, and then doing a multiplex, than doing a fever PCR panel. Bactec blood culture is definitely the gold standard over a salmonella PCR test, and so on and so forth. Like a blood smear or malaria will definitely tell you not only there is malaria, but also which type of malaria, and will also tell you the parasitic index. So there are these advantages of doing tests which have stood the test of time and not jump to shortcuts. But one would use it if you wanted faster results, or you are not sure what you're dealing with, or say for example you want to check for chikungunya as well as you want to check for dengue, and the cost is coming out less expensive. And most important message is that in our discussion we are dealing with monsoon fevers. Now when you say monsoon fevers, the other diseases don't take holidays. Are not on vacation. They are still around with the same frequency. But probably because these fevers have increased incidence, we tend to think of them a little later. And so if you see a child on day 6 who has strawberry tongue, who's peeling from his fingers, who has got this peculiar polymorphous rash, a BCG which is swollen, or the eardrum which is swollen, and the child is extremely irritable, please do not miss non-infective conditions which may not be related to monsoon, and that is your Kawasaki disease. Now we have looked at the common conditions. The other few things that we want to talk about is gastroenteritis. So when you see a child with loose motion vomiting, assume that this is a viral gastroenteritis, especially in the monsoon period. Wait for 48 to 72 hours, give ORS, give zinc, and you can give probiotics because that will hasten the recovery. Though it is not mandatory, it is good to give. Make sure that hydration is proper and the child's nutrition is maintained, child is not kept fasting. Make sure you tell them the danger signs and ask them to follow up if required. Majority of them will settle within 48 hours. Now the red flags here are if there is vomiting with oliguria, if there is blood in the stool, if there is abdominal distension, or if there is vomiting but no stools passed. These become red flags, and one would think about dysentery, intussusception, HUS, etc. And that would be a different discussion altogether. Now let's look at some of the investigations and see that when in doubt whether investigations can at least guide us in making a clinical diagnosis. So we have this patient with fever for 3 days in monsoon, and this is the CBC. So you see the hemoglobin. How are we going to approach the CBC? We'll look at the hemoglobin, then we'll compare it with PCV, whether it is the PCV is 3 times the hemoglobin or more. We will see the WBC and see in what range is the WBC. We will also make a note of whether the neutrophils are more or lymphocytes are more. We will look at the platelets, and just like WBC, we will try to categorize what is the range of platelets. Now, first and foremost, let me put a disclaimer that this is not 100% science. This gives you clues in order to make a diagnosis along with your clinical and other tests. So here, this one, I would like to think about this as a viral infection. Okay, non-dengue viral infection probably. If you see this one here, you have child who has hemoglobin is 10, PCV is not raised, 28, that is within 30. This is 6,500. And here, if you see, everything else is on the lower side. But if you see the platelets are really very low, as low as 35,000. So this child, if he has petechiae, one would think about with this report either dengue or malaria. But because the PCV is within normal limits and the counts are not so low, WBC count, one would think more in terms of malaria. We would also sometimes look at eosinophils to guide you, but that's not always going to be accurate. Look at the third CBC report. You have a report of hemoglobin being 11, PCV is within reach, WBC 4,000. If you see here, it's equal distribution. Though we tend to think of enteric fever with higher lymphocytes, initially you have to remember there are more polymorph nuclear cells. Then later on it gets converted into more of lymphocytes. But majority of the enteric early on will have low eosinophils. And the platelets would be low, but it would be between 1 and 1.5. Usually they don't go below 1 lakh. Let's look at the next one. You have a child with 13 hemoglobin. You see already here the range was around 10, 11. Now you have a 6-year-old with 13 hemoglobin. In India, that itself should be a red flag. But look at 13 threes are 39 and you have 41. So there is some hemo concentration going on. The WBC has dropped significantly. And there is 35-55. So ANC is still above 1,000. And the platelets are going down to 1,50,000. So this is the one where I would think more in terms of dengue fever rather than thinking in terms of malaria. Let's look at one more. The child has a hemoglobin of 8, 8 threes are 24, your PCV still, there's no hemo concentration. Look at the WBC, it's 1,500. And what are the neutrophils? Only 10. So that is an alarming sign. First of all, WBC 1,500 is extremely rare with either enteric or even with dengue fever or with many other virals or enteric. Secondly, neutrophils of 10 would make an ANC, the absolute neutrophil count, as 150. And that should start ringing alarm bells in your head. And we also have platelets which are really very low. So you have low hemoglobin, low WBC, and low platelets. So we are thinking in terms of pancytopenia and would be concerned about malignancies. But also occasionally severe dengue with bleeding can also manifest like this, especially if the previous CBC was here in number 3, which showed a hemoglobin of 11 and a PCV of 33, which after say 12 hours or so of treatment, the child's not looking good and your CBC goes down to, hemoglobin goes down to 8. And then you would start thinking in terms of dengue with bleeding. So just to give you a recap, I have now reversed, I have put this in a different way. If you see platelets around 75,000 versus if you see platelets around 15,000, just like how we said WBC between 5,000 to 3,500, I would say enteric, around 3,500 and lower, I would think about dengue, and anything with an ANC lower than 1000 or total WBC lower than 2000, I would start thinking in terms of bone marrow affection, whatever is the reason, whether it's HLH, whether it is ALL, or whether it is any other condition. Same way, if you see platelets, I'll just show you all the 4 slides. It will be easier to explain. The top one here could be anything. So it's 75,000 platelet count. It could be 14.5 into 3 is not 45. So that I would put it as dengue because there is hemoconcentration and platelets are low. If you see the lower left, lower right corner, another 75,000 are there, but there are low hemoglobin as we showed earlier, and WBCs are not so low. One would think of other causes like malaria, etc. If you see the 15,000 with a happy child, we have all been taught, even if you see petechiae in a child and platelets being 15,000, one would think about ITP, commonly post-viral or drugs, versus a 15,000 in a child who is sick. And then you would start thinking in terms of bone marrow failure, and again think about conditions like ALL. Okay, so it's important to interpret these CBCs in terms of the other parameters on the CBC and clinical conditions. Now, just few words about dengue fever. So these are not new anymore, but we had a previous definition. So putting another one, we call it now dengue fever without warning signs, dengue fever with warning signs, and then severe dengue. So this is how we are going to put our diagnosis. And the classical signs of dengue, to call it dengue, would be an acute febrile illness, classical signs being headache, retroorbital pain, significant muscle pain. There may be some joint pain, but not classically joint swelling or joint movement restriction or joint pain itself. Fever typically lasts 5 to 7 days. That severe dengue can have other manifestations in the form of pleural effusion, abdominal distension, gut ischemia, vitals being compromised, shock, bleeding, etc. But we are focusing just now on outpatient management. So important to pick up flushing. If you pick up flushing, majority of the early diagnosis of dengue are done on that. Okay. Now, what are the warning signs? Very important, because whenever you write a prescription and you write dengue-like illness or dengue without warning signs, please make sure that you mention on paper, either you mention the warning signs or you mention that I have explained the danger signs or I have explained the warning signs. And this is not only for dengue, but almost all the common conditions. Please make it a habit to write one single line, danger signs explained. You will never know when that line could become a savior in case of a medico-legal issue subsequently for that particular patient. So coming back to this patient, abdominal pain and tenderness, persistent vomiting, any mucosal bleeding, lethargy, a CRT which is prolonged, liver more than 2 centimeters, and any sign of clinical third spacing in the sense of ascites or pleural effusion, one would consider a warning sign. Obviously, a rapid drop in platelet count or rising hematocrit also would make you think that this child may have problems and would require urgent hospitalization. Okay. You all know that it's more risky in secondary conditions compared to primary, and adolescents somehow and very young infants are more likely to have complicated conditions with dengue fever. Also, children with pre-existing medical conditions are more likely to have problems with these infections. Okay. So decide about admit or not admit. If you see tachycardia out of proportion, now what do we mean by that? You will know already children have higher heart rate normally. On top of that, there is going to be fever, which is going to push the heart rate. On top of that, looking at you and me, the discussion around parental anxiety, talking about blood test and hospitalization is going to put that heart rate even further up. But in spite of all that, if the heart rate is more than you can account for, then think about it as tachycardia out of proportion, and that could be a sign for impending danger. A decreased pulse pressure of less than 20, meaning the difference between systolic and diastolic, if it is less than 30, less than 20, sorry, then that would become a red flag sign. Any SpO2 less than 94 on room air will be a red flag. Now remember, for very small children, you must have the appropriate probe. The classic COVID clip, as I call it, may not be enough. And also when the child is having very high fever, there is going to be peripheral vasoconstriction and you might not get proper SpO2 reading. Nonetheless, you must recommend that the patient should go to the nearby hospital and get it rechecked about the real value. Any grunting, breathlessness, urine less than 6 times in 24 hours, petechiae, poor intake are definitely considered bad prognostic sign. Platelet count less than 1 lakh is definitely not an absolute indication to hospitalize. But with that, if there are other parameters which are going to be affected and the child is looking sick, one would definitely consider the child should be in the hospital. Remember always, for dengue patient, it's good to err on the side of close observation. Call the patient morning and evening, call the patient daily if you are not going to hospitalize. And make sure you document things very clearly, that if 1, 2, 3, any of these happens, reach immediately to this hospital or any nearby hospital. So that in case of that one rare case where things go downhill very fast, you will be safe. We already discussed that these are the ways to check for capillary refill for newborns. Okay. Now, as I said, we have another disease which is vector-borne, and that's the chikungunya. In children, they have presentations similar to adults, but young children cannot sometimes non-verbal, that I mean, if they're not able to speak properly, it's very difficult to diagnose joint pain because they'll be just irritable, crying excessively, and when you touch them or when you try to move them, then they will be crying in pain. So look out for any joint swelling, especially the ankle, wrist, and any pain while moving the legs or the hand. If you see these kind of hyperpigmentation, that is classically seen in newborns and infants with chikungunya. This is another image which is important to remember. Typically around the nose, brownish discoloration that you see, that is also quite classical of chikungunya. The good part again is that they usually do not land up with arthropathy or arthritis as commonly as adults do, and they generally recover quite well from the joint related problems by paracetamol and at the most a short duration of ibuprofen as needed. So when you discuss differentials, in viral, it is not important to differentiate which virus it is unless, as I said, you are aiming to treat or looking for isolation and protection of this child with pre-medical condition. A splenomegaly in monsoon fever is almost always malaria. Now remember, I am saying splenomegaly, I am not saying hepatosplenomegaly. So if you see a liver palpable and a spleen palpable, you are probably looking at dengue fever, or later on in the end of first week, beginning of second week, of course, enteric fever comes with splenomegaly and hepatomegaly. A joint swelling is highly specific of chikungunya. Different types of rashes are a great help in making a diagnosis of monsoon fever. When to admit? Always remember, the important decision to admit is on organ perfusion, is on vital. So if the vitals are affected, the temperature is very high, the heart rate is out of proportion, the child is breathing fast, the urine output is less because of poor kidney perfusion, child is drowsy, irritable, non-responsive because of poor perfusion to the brain, that is an indication. It's an absolute indication to hospitalize the child. Of course, if there is pre-existing condition, your threshold will be lower. And of course, signs like we discussed, disease specific signs will be important. It's also important to notify, and remember, together we can conquer. So we must help our colleagues who are working with the municipal corporation or with the government body, because if you inform them, there are more eyes and ears on the ground, and they will get an early idea about which epidemic is shaping up. Also, they will know if there are clusters and they can take appropriate remedial measures. It is now extremely easy to report, and there is no such thing that if you report, they'll come and ask you about why you did do this, why you did that, etc. It's very simple. You can put a mail, you can drop a WhatsApp to your respective ward medical officer. All you need to tell is name of the patient, age of the patient, telephone number, address if you have. Otherwise, just disease and the telephone number. They will have their people to trace the patient if needed and make sure that appropriate sanitization, mosquito control, etc. are done. But what should we not do? So we should not give steroids. Children in chikungunya do not require steroids, almost never require steroids. Do not give antibiotics unless indicated. Please do not give antibiotics for dengue fever. Please do not give antibiotics in first 48 hours unless you have a localized bacterial infection. And again, please do not use antibiotics for newborn at all, and for infants without a focus. Make sure at least to get a urine done for young infants before we think about giving antibiotics. Aspirin and NSAIDs should be used selectively, and do not ignore warning signs. Just a few pointers on malaria. You all know how to treat malaria. Severe malaria diagnosis, just like dengue fever, we should know any child with hepatomegaly, dropping platelet count, sugars which are low, abnormal sensorium, deranged coagulation are all considered risk factors. In patients with G6PD, almost so important to remember that all patients, male and female, boys and girls, should be checked for G6PD unless they have been checked earlier. If the G6PD is normal, for Vivax infection, 14-day course of 0.25 milligram of primaquine per day should be given, and a single high dose for gametocidal purpose in case of a falciparum infection. If the child is G6PD deficient and the child has P. vivax infection, as per WHO, you can give higher dose 0.75 milligram per kilogram once a week with close monitoring rather than giving daily small dose. This weekly chloroquine, which many of us have used earlier, has actually no evidence based on that. If it is falciparum and the patient is G6PD deficient, there is no need to give primaquine. Remember, below 6 months, all infants are considered functionally G6PD deficient, and the government recommendation currently is not to use primaquine for any child below 1 year of age, whether it is Vivax, whether it is falciparum, whether the child has G6PD normal report. Leptospirosis, when to suspect, we have already looked at this. If you have history of waddling in the water, which almost all of us will have, but biphasic fever, jaundice, renal failure, conjunctival suffocation, and prolonged fever, hepatosplenomegaly, are important pointers towards leptospirosis. Okay. So just as we looked at platelets, we looked at throat, we looked at WBCs, the eyes are also important clues for fever. So if you see this kind of eye affection, then you think more in terms of purulent or bacterial conjunctivitis. If you see this kind of picture also, this is likely to be purulent conjunctivitis. If you see this child with very red lips, some flushing, and eyes which are red with perilimbus sparing, one would think in terms of Kawasaki disease. And if you see conjunctival sufficient, then you will think in terms of leptospirosis. Here, there is one catch, that even adenovirus comes like this with rash and red eyes, which are not having discharge, so which may or may not have discharge. So that's something which you need to keep in mind. So any child who has very high CRP, high counts, which are not typical of viral fever, but have eyes and GI symptoms in a given season or epidemic, one should consider adenovirus as one of the problems. They have cough also as a predominant feature. Fever with altered sensorium, I have just put one slide because I would just say admit and not think about the cause. Just straight away admit and then manage subsequently. So these are the different rashes that you see. So this is not typical of leptospira. It looks more like an AI generated image, which it is not. This is the flushing that we spoke about. This is not a very clear image, but if you see the hand, which is showing papulonodular markings, you see the knees, which are showing rashes. There are rashes on and inside the mouth. There is later on the the nail bed disconnection and nails peeling off. So this is the whole thing, gamut of hand, foot, mouth disease. But this is the one that I am pointing out. Please do not miss Please do not miss a meningococcal infection or a severe toxic infection. Just because it is monsoon doesn't mean that it is going to be dengue and dengue alone. This we already spoken about. So let's recap. Now this again, as I said earlier, it's not sacrosanct, but if you see, I'm just going to keep everything open so it's easier to explain. So if you see a fever pattern which goes away in 3 days, one would think more in terms of flu or COVID. If it is biphasic, with the second phase being worse, the child having rash, and there is significant headache, tachycardia, and narrow pulse pressure, think about dengue fever. If the fever is by the clock, then you might think of Vivax, but malaria fevers can have erratic fevers because of multiple crops of of the Vivax. If the fever started high and remained high, then look carefully at the throat, the ear, the urinary tract infection, and if at all, this would point towards a localized bacterial infection. But on the other hand, if you got a rash on this child which started around the face with sparing of the perioral region, and it was rough with predominantly around the in the elbows and behind the knees, then you would start thinking in terms of scarlet fever. If you had a child with fever which was not so bad in the first couple of days but kept on increasing and now has liver and spleen, one would think about non-localizing bacterial infection and think about enteric fever as a cause. This I think we have already discussed, but just to give you a one view on this, if you see tonsillitis as a bacterial infection, typically you will see increased WBC counts and predominantly neutrophilic counts. Platelets may be normal or slightly elevated as a marker for inflammation. Rest of the things we have already spoken about. So take home message here is very clear. History is very important. There is no emergency if there are no red flag signs. The first important thing is child is sick or not sick, and that applies for everything, not just for monsoon illness. Be judicious in using investigations so as to come to an early diagnosis and prevent unnecessary treatment as well as complications. And whenever in doubt, in monsoon, please admit early. Of course, as I said earlier, monsoon illnesses are not the only cause of fever in monsoon. And so please don't forget that you will not have Kawasaki, malignancy, tuberculosis, urinary tract infection, acute otitis media, pneumonia, etc., which are other common causes of fevers. Thank you very much. Dr. Sanika, I'll stop here and take questions if any.
Yes, sir. Thank you so much for this presentation. Like a lot of
Thank you.
comments have said, it has been a very informative session. and we have a few questions here. One question by Dr. Ravindra Kulkarni is how to manage dengue shot syndrome.
I think we'll have to ask them to arrange a session for us, because this definitely, the only outpatient management would be to identify it early by making sure there is no narrow pulse pressure, there is no out of proportion tachycardia, CRT is normal, urine output is normal, and to diagnose it early and admit and allow the person to handle dengue shock syndrome.
Yes. So, one more question by Dr. Ravindra is which is ideal antibiotic for Shigella dysentery?
So this is actually a matter of discussion, because Shigella dysentery, the ideal antibiotic is third generation cephalosporin, but there are certain strains of E. coli which behave like Shigella, and if you give antibiotics, then you increase the risk of hemolytic uremic syndrome. So that is the discussion, but a short answer to your question would be a third generation cephalosporin. Oral cefexime would be a good one to start.
Yes, sir. Sir, here is a question by Dr. Bharat Bhushan Agrawal. Is since blood culture report is delayed, which is better, blood Vidal or typhidot in a suspected case of enteric fever?
Yeah, so I mentioned earlier for the other session, Dr. Tushar and me are very good friends. And at many of the sessions, we like to raise our hands and make everybody take an oath that I will not do Vidal test. And corollary to that, if I see a patient who has a Vidal report and has my name written on referred by Dr. Tushar Maniar, I write on that I did not ask for it, so that nobody should get a wrong impression that I have changed sides and I'm now asking Vidal. As far as typhidot is concerned, the specificity and sensitivity is not very good. Now, whether to start treatment on typhidot or not is questionable. If you because I'll give you a scenario like this: you have a clinically strong suspicion of typhoid, then you will start treatment any which ways, whether typhidot is positive or not positive, whether the culture report has come or not come. Culture is you are awaiting culture, negative culture, or positive culture. All three scenarios you will be giving the antibiotic. The advantage of doing the test is, one, if you get a culture positive and the fever is taking some time to settle, you will be confident in waiting. Patient and the parent will also listen to you and wait for you to not jump around doing more investigations and going to higher antibiotics.
So we have a question by Dr. Desai here. What is the importance of immature platelet fraction or mean platelet volume in cases of dengue in children?
Madheva is taking my exam actually. He has taken a very nice session on adult monsoon fevers for adults, and all of us listening should go back on Medflix and listen to it. It's a very nice lecture. So immature platelet fraction help us in deciding or what you call identifying the reversal of dengue. So if you see the immature platelet fraction and the child's platelets are dropping, you can say that now there is going to be a turnaround in maybe 24 hours or 48 hours. Again, clinically, we would rather do it. So for children, we do not do daily CBCs. If the child is comfortable, for hospitalized patients, I would be doing it daily.
Okay.
And mean platelet volume also, the platelets which come out faster sometimes are larger in size, and that helps us to diagnose again the reversal that the platelets have started coming out of the bone marrow. Otherwise, open to correction if you want to add anything.
So we have a couple of same question here. Is what is the dose per kg of zinc in gastroenteritis?
So we don't give zinc as per kg body weight. We give 10 milligram and 20 milligrams. Below 1 year, 10 milligrams. Above 2 year, above 1 year, 20 milligrams. 7 days.
So one of the last questions here. Many pediatricians commonly get CRP done. Is it helpful and how?
So yeah, I'll be honest. Even I get CRPs done. they are useful not necessarily to say this is viral or bacterial, but it's sometimes useful to tell us what is the severity of the toxins generated, what is the when you are in doubt about viral versus enteric. But again, as I said, most of the time you will end up doing the taking a decision based on your clinical and other parameters. I personally am not against CRP as some of our teachers are.
That is
Of
it.
course, it
That
is
is
very useful when you are thinking in terms of non-infective conditions, like if you're thinking of Kawasaki and you are sending a CRP, that's a totally different indication, and that nobody will doubt that. But I'm sure this question, when you say commonly get, it means that for routine viral versus bacterial. So viral versus bacterial, CRP is not necessarily helpful unless it is really very high. It's like it's 100, 200, then you are more likely to be talking about bacteria.
I think that is all the questions in the comment section for now. Thank you so much, sir, for joining us today and discussing this important topic and breaking it down to the T and explaining all the aspects of monsoon illnesses. Thank you for the audience as well for joining us today.